All right. Hello, everyone. Welcome to today's Rafael Medina Subspecialty VMR. I'm super thrilled to be here with you all today. My name is Elena, and I'm a medical graduate from Germany. We have two fantastic educators today, and the focus of the session is going to be oncology. Before I introduce our discussants and case presenter, I want to thank Julia and Rahul, who are going to be scribing and doing the teaching points today. All right, so our first educator is Dr. Neelima Vidula. She's a breast medical oncologist at Massachusetts General Hospital and an assistant professor of medicine at Harvard Medical School. Dr. Vidula completed medical school and residency in internal medicine at the Northwestern University in Chicago and did her fellowship in hematology and medical oncology at the University of California, San Francisco. In terms of research, Dr. Vidula is the principal investigator of many early phase clinical trials studying novel agents for patients with breast cancer. Dr. Vidula, why don't you say hi to everyone, and maybe you want to share something that you enjoy doing outside of medicine?
Thank you so much for having me. It's really a pleasure. When I was a resident, I used to really love morning report, so it's really great to be back and to be in that type of forum. Outside of medicine, I actually enjoy running quite a bit, so I enjoy the outdoors. I also enjoy travel with my family.
Are you more the long runner or a short distance runner?
More of a runner for pleasure. Okay, so not doing any races, but just running for enjoyment and being with nature.
That sounds fantastic. Thank you so much. Yeah, and last but not least, we have Andrew Knight, who's going to be presenting the case today. He's completed his internal medicine residency at the University of Pittsburgh and is currently a PGY4 and hematology oncology fellow at the Massachusetts General Hospital. Andrew, you told me yesterday that you didn't always wanted to go into oncology. From your perspective now, why is it such a cool subspecialty?
Well, I think we really have a combination of a couple different things there. One is the patient care, and I think you have to start with that. The patients that we get to work with, it's really incredible. But also, the research in oncology has just exploded over the last couple of years. We have a lot of new drugs, new agents coming into the space, and continually improving outcomes. So it's great to be a part of that.
Yeah, great to have you both today. Super excited for the case and for the discussion. Julia, if you want, you can bring up the whiteboard, and whenever you're ready, Andy, we can start with the case.
All right. Fantastic. So we have a case of a 57-year-old woman with a past medical history of DCIS, that's ductal carcinoma in situ, status post a bilateral mastectomy back in 2012 with subsequent reconstruction, otherwise healthy, and she's presenting to the emergency department today with chest pain and low back pain for about the last 9 months.
Thank you so much, Andy. Very interesting first aliquot. Dr. Vidula, I'm curious how, with the many years of clinical experience, you in general approach chest pain, and then the combination with lower back pain is certainly interesting, and how you layer in the history of the DCIS of this patient.
Thank you. So when you think about a woman who's, in her late 50s, who's coming into the emergency room with chest pain, of course, the first thing that you need to be thinking about is ruling out diagnoses that could be life endangering. So a heart attack, MI, PE, aortic dissection, these types of things are, if it was bad enough that this woman unfortunately had to come into the emergency room, I think you definitely need to rule out life endangering events. So that's definitely something that's high on the differential, and something that needs to be ruled out. In terms of chest pain and lower back pain, I think the other thing that you worry about could this be some type of a rheumatologic illness, some type of a pericarditis, and then she has arthritis or so forth. The history of the DCIS does make me also put cancer on the differential. DCIS, typically, if it's going to recur, it's within the first 10 years. And we'll definitely need to get more history on how the patient was treated. But after a bilateral mastectomy, it would be a little bit unusual to be presenting with distant metastases. So we'll have to find out how far out she is from her diagnosis. But in one study that has been conducted looking at patients who underwent a mastectomy for DCIS, they found that the rate of isolated local recurrence, that is in the chest wall, was about 12%. Local and regional recurrence is about 6%. And isolated distant metastases occurred in only 12% of cases. So even though that's on the differential, it's a little less common, and something that I think we need to kind of find out more about her history. When was the DCIS? How was that treated, and so forth, but definitely on the differential.
Yeah, super, super interesting. Thank you so much, especially for like layering in how the DCIS might or may not play a role here. I think something else that is certainly interesting in this patient is the 9 months history of, the chest pain and back pain. Usually in the acute setting, we have patients who maybe have had chest pain for a couple of days. Does it change your differential? You've mentioned some of the emergent causes that definitely need to be ruled out. How are you thinking about this with the chronicity of the history?
Absolutely. So, I think that for this patient, because they came into the emergency room, clearly this was something happened. If it's been going on for 9 months, something acutely made this worse. So I do think you still have an obligation to rule out the acute types of events that can be life endangering, such as an MI, such as a PE, aortic dissection, and so forth. But you're absolutely right that when I think about the chronicity, that this has been going on for 9 months, then I'm thinking more about chronic medical issues. And at that point, something like rheumatologic issues, some type of arthritic condition, and cancer actually gets a little bit higher on my differential because that's more of a subacute presentation than an acute presentation typically.
All right. Thank you so much. That was super helpful. And is there anything you want to add, or just continue with the second aliquot?
I'll just add 2 pieces of information to contextualize the DCIS. So this was treated 12 years prior. It was treated surgically, no adjuvant radiation, and she had bilateral mastectomy. And somebody astutely pointed out in the chat there that it's a little unusual she had a mastectomy. We do that in some cases, which Dr. Vidula can maybe talk more about later. But specifically, she had it because they were unable to achieve negative margins with lumpectomy alone.
Yeah, I certainly can speak to that a little bit more. So just taking a step back, because I think we have some, residents and maybe even medical students joining us. DCIS stands for ductal carcinoma in situ. So it is the earliest form of breast cancer. It's what we consider a stage 0 cancer. So cancer is staged all the way from stage 0, where it's an early form of cancer, all the way to stage 4, where that unfortunately is metastatic disease, incurable cancer. So the goal of treating ductal carcinoma in situ is to help reduce the chance of that progressing into a true invasive breast cancer. So ductal carcinoma in situ, the way we often explain it to patients is kind of as having cancer cells that are sitting around in the ducts of the breast, but they haven't gotten smart enough yet to break into the surrounding tissues, which would upgrade it to a stage 1 or higher cancer. So in terms of managing DCIS, typically the first step is surgical management if we're considering an intervention. So, in many cases that may just be a lumpectomy, but some patients, of course, because of their preference, might opt for a mastectomy. Or if there's a lot of DCIS that's present and perhaps the surgeon is a little concerned that they may not be able to remove all of it with just a lumpectomy with a good cosmetic outcome for the patient, then a mastectomy might be considered. Another situation where a mastectomy might be considered is if a patient has a BRCA known mutation, strong family history of breast cancer, ovarian cancer, and so forth, and test positive for a BRCA mutation. In that kind of case, we might consider a bilateral mastectomy because there's a higher risk of developing breast cancer. But it is rather uncommon to see a bilateral mastectomy done for DCIS. My guess is that this patient probably wanted to be proactive and reduce the chance of having to have a future breast surgery in the contralateral breast. And maybe that's one of the reasons why she opted for a bilateral mastectomy. But certainly we would want to hear a little bit more about her family history, find out if she's ever had genetic testing to hear more about that. And then following initial surgical management, again, if a patient has had a mastectomy, typically we would not give radiation in that setting, but radiation can be considered in patients who've had a lumpectomy, and that's to help reduce the chance of a local regional recurrence, meaning the breast cancer coming back in the same breast or lymph nodes, typically as an invasive, ductal carcinoma in that same breast. So radiation actually can help reduce that rate of recurrence in the local setting by about half, 50%. And then we also need to know the receptor status of the DCIS. So if the DCIS is estrogen receptor positive, there is data that you can consider hormone therapy such as tamoxifen, or there is one study looking at anastrozole in women under 60 and show that that could also be used in that setting, an aromatase inhibitor. And the goal of hormone therapy for this type of early phenomenon, DCIS, is to reduce the risk of developing an invasive breast cancer in the same breast or the contralateral breast or DCIS in both breasts. And, on top of radiation, that probably adds, maybe an absolute benefit of 3 or 4%. And it's not actually associated with an overall survival benefit as it is in patients who have an true invasive breast cancer stage 1 or above, because the overall prognosis for DCIS is typically very good. Usually we're quoting numbers of a recurrence by about 10, maybe 15% at 10 years, and mainly those are local recurrences. And again, hormonal therapy would not be used in patients who've had a bilateral mastectomy, because then there's no role for chemo prevention of the other breast that wasn't affected by the DCIS, because there's no breast tissue. Does that make sense?
Yes, it certainly does. Thank you so much for elaborating on that. I think one question that I have, because you've a little bit talked about the rate of recurrence, and now that we know that the DCIS was diagnosed like 12 years ago, how do you think about the current presentation now?
Yeah, so, this would be highly unusual, really, to see metastatic disease after having had a bilateral mastectomy for DCIS. Now, that being said, those of us who are oncologists, unfortunately, with time, you're humbled by the nature of cancer, and you realize that cancer can really, at the end of the day, do whatever it wants to do, unfortunately. So, we can quote numbers and we can look at studies and have a general sense of things, but certainly there may always be situations that are anomalous. But as I was saying earlier, that there was actually one study that looked specifically at rates of recurrences and sites of recurrences after management of DCIS, in a cohort of patients. And what they actually found was that in patients who had undergone a mastectomy for DCIS, the rate of an isolated distant recurrence, meaning cancer coming back outside of the breast and lymph nodes, like in the liver, the bones, some other distant site, was 12%, and the median time of recurrence was about 5 to 6 years. So when you think about those types of factors, yes, although a malignancy is on the differential here, this patient is kind of out of the window for that, what you would typically think of as a recurrence of DCIS. And secondly, the rate of presenting with a distant metastasis is pretty low. It's 12%. So, even though it's on the differential, I think you also need to work up other etiologies in this patient.
Yeah, thank you so much. Andy, do you want to give us the next aliquot?
Absolutely. So moving on to the HPI here, this patient presented to the ED, as I mentioned, for chest pain that had been going on for 9 months. It initially started after a ball game, and she said that she initially attributed the pain to possibly being a muscle strain, but instead of improving, the symptoms actually worsened over time. Initially, the chest pain was mid-sternal. She described it radiating bilaterally with some rib pain, and also some radiation to the mid-back. The pain was worse with moving her arms and legs, but was notably not worse with exerting herself. She also said taking a deep breath, laughing, coughing, or sneezing would exacerbate the pain. Independent of that pain, she also had a separate pain in her low back, which had started actually more like just a couple months ago. And she said that it was a little bit to the right side in her low back. And this pain, both in the chest and the back, had started to limit her activity considerably. Now she's taking ibuprofen a few times per day. And because of how long these symptoms had been going on for, she figured she should be evaluated and presented to the ED. There was nothing particularly worse on this given day. It was just the persistence of the symptoms, which was why she presented. I'll just mention in review of systems here, negative for shortness of breath, any bowel or bladder incontinence, lower extremity pain, weakness, no redness or swelling, warmth in any of the areas described, no fever or chills, no leg swelling or calf pain, and no rashes or other lesions on her skin.
All right. Yeah, this is very interesting. So we get a little bit of more information about the quality of the pain, about its triggers, about with what it is associated. Does this change your approach at this point to how the patient is presenting, Dr. Vidula?
Yeah, so it's great to have a little bit more history here. I think that given that now we understand the chronicity a little bit better, and we also understand that this has been, this was not an acute presentation, really. This is more of a subacute type of presentation. I think that some of the things that we talked about that are still, I think, important to rule out since the patient came into the emergency room, like ACS, PE, and aortic dissection, probably fall lower on my list, because now I'm wondering, why is this patient having these symptoms for 9 months? And it's not pleuritic, it's not exertional. So it makes me think that a cardiac or a pulmonary etiology is likely less likely to be the cause here. I think that, with this mid-sternal pain that's radiating bilaterally, and the history of the DCIS and the surgery, sometimes after having had breast surgery, patients do develop pain and chest wall pain and sternal pain. So that's often just due to nerve damage or damage from the prior surgery, even though the onset here seems a little unusual that 12 years after having had surgery, she's suddenly presenting like this. But I think that is something that can be considered as well. I would worry because this all started after a ball game. I don't know if she was hit by a ball or something. Did she develop like some type of a fracture? But then one would have thought that, 9 months after having that, hopefully the fracture would have healed. But I think that you have to keep that on the differential musculoskeletal etiologies as well. And then with the low back pain, so it sounds like typically for low back pain, we're thinking, initially most PCPs would start with, a trial of ibuprofen. Most of the time, this is musculoskeletal in nature, so a little bit of ibuprofen, icing it, doing maybe a little bit of physical therapy. But it sounds like this patient has done some of that, maybe had some ibuprofen, a trial of ibuprofen with no relief. So when I think about back pain and musculoskeletal pain that's not remitting, again, probably the two highest types of disorders that fall on my list are something rheumatologic in nature or something that is oncologic in nature, because now this is something that's persisting. Its presence is, is definitely being made known. And I think you want to think about arthritic conditions. Does this patient potentially have like rheumatoid arthritis, although it's a little unusual that she would have just back pain, and but the sternal pain certainly could be seen in that setting. Otherwise, something like ankylosing spondylitis, even though, she doesn't have any other symptoms or a history that's consistent with that, but that I think would also be on the differential. So I think you have to think about these types of rheumatologic issues. And then I think you also have to worry about cancer. And, given her history of DCIS, even though it is, as for all the reasons we talked about, a little unusual that she would be presenting with a distant recurrence, I think breast cancer is on the differential. And when we think about, age appropriate cancer screening, she's in her 50s. So probably, breast cancer is still really out of the oncologic conditions high on my differential there. But I think you also have to think about other things like, multiple myeloma that could present with bone metastases. A lot of solid tumors can present with bone metastases, but in her age group, colorectal cancer would be something to think about, although it would be a little unusual to present with isolated bone metastases in that setting and not have any type of abdominal symptoms that would clue you into that.
Yeah, thank you so much. I'm certainly very intrigued by the combination of the chest pain and the lower back pain. We know that bone metastases are one of the most common sites for breast cancer metastases. Are there any red flags you would watch out for that would point you towards malignancy in terms of the quality of the back pain, or any other things that you watch out for on labs, for example?
Yeah, that's an excellent question. So I think that I would go back and ask the patient, how did you feel after getting ibuprofen? Was there any improvement? Cancer is usually not shy about making its presence known. So if there's a bone metastasis, with time that will likely grow when it's untreated, and it will likely cause more pain and more symptoms. It's, things that usually tend to improve with ibuprofen are musculoskeletal etiologies of back pain. You unfortunately had suffered some musculoskeletal strain or some arthritis. Those often improve with ibuprofen. So I'd really want to go back and hear from the patient how, you mentioned that these symptoms have been going on for 9 months, but have they been progressively worsening? Have you noticed any relief from ibuprofen, or do you feel like things are getting worse with time? And I think that type of unremitting pain, worsening pain with time is usually what we actually in clinic tell our patients who've had breast cancer, to watch out for, because that could be a red flag symptom.
Thank you so much. Maybe one last question before we pass the mic back to Andrew. In terms of workup, if you were seeing this patient at this point, what is kind of the workup that you would initiate for this patient at this moment?
Great question. So first of all, we have to think back to the setting we're seeing this patient in, right? So this patient is in the emergency room. So the goal of the emergency room doctors, of course, is to catch anything that's life-threatening and help triage the patient. So I think as a starting point to this patient, because you said the magic words, you unfortunately presented with chest pain, you have to have an EKG, you have to have troponins, you have to have a chest X-ray to rule out ACS, to look for widening of the mediastinum that might clue you into aortic dissection. And these are all tests that can be done quickly, so typically would be triaged up front. So that's, I think, definitely something that would need to happen. I would also definitely recommend getting a CBC and a comprehensive chemistry panel, because, that might clue you into any, if her calcium's through the roof or she's anemic, maybe I'm thinking more myeloma, if I see a protein gap, things like that. That might clue you into that diagnosis. I'd probably send some rheumatologic markers, maybe a CRP and ESR, to see if those are elevated. And then I think that, because this, I definitely examine the patient too, and see if there's anything palpable on exam, any kind of a mass or anything that you can feel in the sternum. Eventually, I think because cancer is on the differential, although these are the starting points, I would probably think about having some CT scans done, because I think, she and also you have PE on the differential, although it would be a little unusual to present like this after 9 months, with the chest pain, and the back pain doesn't fit into that. But I think that eventually she will likely need some form of a CT chest, whether you get a CT angio or just a pure CT chest. Probably a CT angio would be high yield, because it would be a 2-for-1 to look for metastases and also rule out PE, since that is on the differential, although lower. And then ultimately probably a CT abdomen and pelvis, and either a bone scan or a PET CT. But I think, she's going to end up getting a fairly significant workup, is what I would guess.
Yeah, fantastic breakdown. Thank you so much. Just out of curiosity, so I learned in med school that the types of bone lesions that breast cancer usually causes is osteolytic lesions. If we presumably think that this might be, the back pain might be from, metastasis from potential malignancy breast cancer, do you see an elevated calcium frequently with this kind of metastases?
That's a good question. I don't think that it's that common. Hypercalcemia certainly can occur with malignancies, and it's good to check the calcium, but not in every case, because it just depends on how much bony turnover there is there, and what's the burden of disease. But certainly, a lot of patients with, estrogen positive breast cancer, early stage breast cancer, when they unfortunately develop a recurrence of that disease, often it's a bone-only presentation, but in the vast majority of cases, the calcium is not necessarily elevated. Now, in some cases it will be, and if it is, that should be worked up, and you should, treat that appropriately, maybe with like a bisphosphonate to help lower it, which would not only lower the calcium, but would also help treat the bone metastasis.
Thank you so much. Andy, mic back to you.
All right, great. So just a couple points I would clarify there on the HPI. So she does describe a pleuritic quality to this in terms of the pain getting worse with deep inspiration. The pain has been getting steadily worse over the last 9 months. She said originally it was just a mild irritation, and now it's really limiting what she can do at work. And the ibuprofen, she's not sure if it helped at all. If it did, it was very minimal. And so with that, I'll move on to give some additional information about her past medical history. We've discussed her DCIS history. I'll just also add some relevant OBGYN history. She underwent menopause at age 50, no prior hormone replacement therapy, no other past medical history to note. Past surgical history, she had 3 lumpectomies prior to the bilateral mastectomy and had subsequent reconstruction afterwards. In terms of her family history, her mother had AFib and heart disease. Her father had Alzheimer's. She has 2 healthy children, and there's no family history of breast, ovarian, or other cancers that she's aware of. She did not have prior genetic testing. Her social history, she's married with 2 children. She works in sales, no occupational exposures that she's aware of. Tobacco, she never smoked, doesn't drink any alcohol currently, and has no history of prior heavy use, no recreational drug use. And she is sexually active, just monogamous with her husband. With regards to her physical exam, she is well appearing and no acute distress. She has moist mucous membranes, no adenopathy. Her heart rate is normal, as is the rhythm, no murmurs or rubs or gallops. Lungs are clear throughout. She does have some tenderness to palpation along the area where she indicates pain, along the mid-sternum. Her abdomen is soft, non-tender, non-distended. Extremities warm and well perfused, and no rashes, no focal weakness or neurodeficits noted. So really the notable findings there, just tenderness to palpation in the chest, and also she does note some tenderness to palpation on the right in the low back.
Yeah, thanks so much, Andy. Dr. Vidula, would you mind giving us just like a problem representation, like how you're thinking about this patient at this point, and if the last aliquot changed anything for you?
Yeah, I think so. With the additional history, this is making me think a little bit differently about the differential. So now that we hear that this pain has a pleuritic component to it, I think you are obligated to rule out a PE. So that, is something that I would definitely be thinking about as well. In terms of the management of the back pain and just this pain overall, the fact that it hasn't improved really with ibuprofen is making me concerned that there might be a brewing malignancy here, also given her cancer history. And then I think the last thing that I would just consider as well is, given that there's tenderness to palpation, costochondritis, I think, should be on your differential too. And, even though the overall presentation, typically you wouldn't have costochondritis for 9 months, and it would have hopefully improved with ibuprofen. So, but I think that is something else to, put on the differential as well. But I am more concerned about a malignancy right now because of the history that this isn't really getting better with ibuprofen, and it's actually getting worse with time. So that suggests to me that there's a larger problem here going on.
Thank you so much. So you have been talking a little bit about a potential thromboembolic event in the chest, like a PE. Is that something you commonly see in patients with malignancy, particularly breast cancer?
That's a very good question. So unfortunately, malignancy is a risk factor. An active malignancy is a risk factor for developing a pulmonary embolism or a DVT. In this case, again, this case is a little unusual because the DCIS was 12 years ago. So DCIS, I typically wouldn't think of as being associated with PEs or DVTs, because it's more of on the spectrum of cancer, a little bit more towards the benign side of things. But certainly in patients who who have a known malignancy, they are hypercoagulable. We know that. So forming clots is something that can occur. And that's why it's very important to be on the lookout for that in patients who have an active malignancy, and to manage that appropriately.
All right. Andy, we're ready for the next aliquot.
Great. So when she arrived to the ED, she promptly got an EKG, which showed normal sinus rhythm with occasional PACs, no evidence of ischemia. Troponin for her was less than the lower limit, so negative there. She also had a CBC, which I'll just give the white count was 4.66, hemoglobin 13.5, hematocrit 41.6, and platelets 226. She had a BMP as well, which showed a sodium of 141, potassium 4.2, chloride 106, bicarb 28, BUN 16, creatinine 0.66, glucose 87. So in summary, a normal CBC and BMP there. She did undergo a CTA. They wanted to obtain chest imaging, and because PE was on the differential, they went ahead and performed a contrasted scan to evaluate for PE, which was negative for PE, but did reveal bony destruction of the sternum with soft tissue extension, highly concerning for malignancy. And so the patient at that point was admitted for further workup.
Yeah, that's very interesting, Andrew. Yeah, we have a lot of negatives on the labs, but the imaging is certainly very concerning. Dr. Vidula, what are you thinking right now, and what would you do for this patient?
All right, so good. First things first. Good news is that we're not dealing with an MI. The tropes are negative. The EKG looks fine, so that's one thing we don't have to worry about here. Great. There's no PE, so just thinking about those acute things. You're in the emergency room. You're an emergency room doctor. You want to rule out the acutely life-endangering conditions. There's no acute PE. There's no ACS. The CT angio, of course, didn't show a PE. And of course, the CT angio would have also been able to evaluate for an aortic dissection, which was much lower on our differential, but nothing there too. So I think we can safely say that we've ruled out the acutely life-endangering issues. In terms of labs, so the basic labs look okay. So I'm less, and the calcium I think wasn't elevated. Sorry, did you mention that?
The calcium was not elevated. It was 9.3.
Okay, was not elevated. So so this is even though myeloma I think is on the differential with a normal calcium and normal hemoglobin, normal CBC, no prior known exposures to any kind of chemical exposures or so forth, I think that falls less on the differential. The thing I'm most worried about now is that now we have on the imaging this finding of bony destruction of the sternum and a soft tissue mass essentially. So now I'm worried that could this be malignancy? And I think the other things on the differential for a soft tissue mass that you see in the sternum are also, of course, you want to rule out infection. I don't think this patient has an infection because her white count is fine. She's not febrile, so unlikely to be infectious. And given the history of the DCIS, now I am worried that could this be breast cancer that has recurred locally in the chest wall? And could that perhaps explain her findings? I think other malignancies, of course, are also on the differential, but a little bit lower on the differential because the history of the DCIS makes me more concerned about breast cancer, also given her age and the fact that she's a woman, puts breast, I think, higher on the differential. But certainly other things that you could think about as well are other malignancies, for example, lung cancer, but that seems less likely because she doesn't have any lung nodules or a lung mass seen on the CT of her chest. So really, I think that the highest thing on my differential right now is actually a breast cancer recurrence.
Yeah, that's very interesting. So at this point, with the concern for potential recurrence, how would you work this patient up? Would you biopsy, and if so, where?
Excellent question. So first off, I would recommend a little bit more imaging because you're absolutely right. She's going to need a biopsy to confirm the diagnosis. We actually do recommend doing a biopsy at the time of a potential recurrence for 3 reasons. The first is that you want to confirm the diagnosis that this is actually a cancer, and that secondly, that you want to confirm that it is breast cancer because cancers are treated differently. And then the third reason is that we want to see what the receptors are. Breast cancer, assuming this is breast cancer comes in different flavors. We always test for the estrogen receptor, the progesterone receptor, and human epidermal growth factor receptor 2 or HER2 receptor. because those are that allows us to distinguish the breast cancer into a subtype of breast cancer, and the management of the cancer in terms of targeted therapies and treatment options is highly dependent on knowing that information. So those are the reasons to get a biopsy. And I would actually add a fourth reason, which is that, in most academic centers, for sure, we often will send next generation tumor sequencing that is looking at mutations that are present in the tumor that were acquired by the tumor that may help us to find and identify targeted therapies for patients down the road. So that's another reason to think about it, and having that tissue available also for a clinical trial participation. Often many clinical trials ask patients to have tissue available is another reason to do it. In terms of knowing where to biopsy, this is why it's really important to get additional scans. There's also in this patient, she's been having back pain. So I would be worried, does she have a metastasis potentially in the spine that is causing her symptoms? So I would definitely recommend additional imaging. Typically, we would start with, a CT chest, abdomen, pelvis. She's had the equivalent of a CT chest already with the CT angio. So she can have a CT abdomen and pelvis, and then either a bone scan or a PET component in addition to the diagnostic CTs to evaluate for bony metastases. And then I think in this patient, depending on what these initial scans show, because she's been having quite a lot of back pain, it's also not unreasonable to get an MRI of her spine to evaluate the total spine and, make sure that, she doesn't have any red flags on her history in terms of cord compression. Her neurologic exam, I think, was fine, and hasn't had like stool or urinary incontinence or weakness in her lower extremities. So cord compression is less likely, but I think that it might be good to think about doing some imaging of her spine, like an MRI spine. But you can start with the CT, abdomen, pelvis, and bone scan or PET scan.
Yeah, thank you so much for walking
And then,
us through.
sorry, the last point I wanted to make is regarding the site to biopsy. You always want to cause the least amount of harm to a patient. We would recommend biopsying a distant site because that allows us to not only stage the patient, confirm that this is a stage 4 cancer that has progressed, but also to again, check the receptors. And in about 10 to 15% of cases of breast cancer, the cancer can actually mutate from its original receptor status to the site of presentation in the recurrence. So that's another important reason to think about biopsying a distant site. Now, I don't think we actually have receptor information on this patient's initial DCIS. Am I correct about that?
That's correct.
Yeah, thank you so much for walking us through all of the staging and how we approach this patient at this point. I was wondering if there's any value of tumor markers at the point right now, or yeah.
So tumor markers actually are, you could certainly send some, but this patient's in the emergency room, so chances are you'll probably be able to at least get the CT abdomen and pelvis fairly quickly. And my guess is the PET and the bone scan in the next couple of days. But tumor markers are actually very helpful in the setting of allowing us, once a patient has a diagnosis of a recurrence or a stage 4 kind of cancer, to follow them with treatment, because you don't repeat. Part of the treatment for a malignancy such as an advanced or metastatic breast cancer is that you start a patient on a treatment, but you follow them. A couple months later, you'll do imaging scans to see how the tumor is actually responding to treatment. And in between, though, an easy way to kind of get a sense of, are things progressing, are they headed in the right direction, is to trend tumor markers. But that's really mainly helpful if a tumor marker was elevated at the time of diagnosis. If it was a normal tumor marker, trending that probably is not going to be super helpful. But if a tumor marker was elevated at the time of diagnosis, and then you start them on treatment and you see that it's downtrending, and then with a couple of months it's uptrending after there's progression on that therapy, that could be helpful. So in this case, I probably would send some tumor markers, because I think the pretest probability at this point is high for a breast cancer recurrence. So typically we would send a CEA, a CA15-3, and a CA2729, and see, those are the ones that are typically associated with breast cancer recurrence and metastatic breast cancer.
Yeah, thank you so much. Andy, Mike, back to you.
Great. One question I had there, you mentioned that it's beneficial to biopsy distant disease. What are your thoughts about biopsying a bone lesion versus a soft tissue lesion?
Great question. So this comes up, unfortunately, fairly commonly in the management of patients with cancer or presumed cancer. One of the issues with getting a bone biopsy in patients who we're concerned have a breast cancer recurrence is that the receptors actually can be decorticated sometimes on the bone tissue. So if you have a soft tissue lesion like a liver mat or a lymph node, that's typically preferable. That being said, one way to circumvent that, as I mentioned before, some patients who have hormone receptor positive breast cancer often may present with a recurrence as a bone only recurrence. And then, that's all you really have available to biopsy. So a way to kind of circumvent that is that if there's a soft tissue component to a bony lesion, that's certainly something that could be biopsied. And I think that the last teaching point I'd make here is that if a patient really does have bone-only disease, first of all, that's probably generally a better prognostic marker than having liver metastases or a lung metastasis or brain metastases, for example. So if they really only have bone-only disease, then I'd probably just say go for it and biopsy it, because you do need that confirmation for all the reasons I mentioned before, that this is really a malignancy, that it is really the malignancy you think it is, a breast cancer, and then to get as much information as you can as possible.
Andrew, you have us at the edge of our seats. What did you do next?
All right. So just to answer two questions in the chat there, she did have LFTs, which were normal, and the genetic testing, she had never had prior genetic testing. So what happened next was she did get tumor markers, which resulted a few days later. CEA was very mildly elevated, 3.5, upper limit is 3.3. CA 15.3 was 16.2, which is normal. CA 27.29 was 17.8, which is also normal. She did have a PET scan done, which showed multiple osseous lesions. So she had lesions in the sternum, as we saw in the chest CT, but she also had lesions in multiple thoracic vertebral bodies, in the pedicles of the lumbar spinous processes, and throughout the sacrum and iliac, with some soft tissue component noted on the iliac lesions, as well as the posterior acetabulum, right scapula, and right ninth rib. At that point in time, she was discharged, arranged for outpatient, she was discharged, arranged for an outpatient biopsy, which she had. The soft tissue biopsy of the iliac lesion was obtained, which showed metastatic ER positive, PR negative, and HER2 positive. It was graded 3+ breast cancer, and she was started on first-line therapy with pertuzumab, trastuzumab, and paclitaxel. Also started on Zometa every 12 weeks.
Thank you so much, Andy. I think before we talk more about the medical part to this, for the patient, this is certainly like a life-changing step right now. So I would just be curious, how in such a situation you talk to a patient, how you approach them and their family. What is a good way or tips that you can give all of us, how you talk about such a situation with a patient?
So I think that that's a really great question. We definitely need to always show compassion towards patients and understand the high level of anxiety that surrounds a possible cancer diagnosis or recurrence. So in this type of setting, if a patient has these scans that are showing multiple findings that are concerning for a malignancy, in this case, some widespread bone metastases, I think that it's really important to be honest with patients, but at the same time to be compassionate. So typically my approach to patients in this type of setting is to tell them, look, we are in the information gathering stage. You came in with, in this case, you came in with chest pain and back pain, and we've done some imaging, and tell them what the facts are. So the imaging, unfortunately, is concerning for multiple spots in the bones, and tell them the area, tell them the areas to the degree that they want to hear about it. And this may explain why you've been having these symptoms of pain, but we need more information. And while the presentation overall, one of the things we are worried about because of your history of cancer is that could this be breast cancer that's unfortunately recurred? We definitely need to get some tissue confirmation to make that diagnosis and to decide and determine how to treat you appropriately and how to manage it. So the next step I would recommend is a biopsy of a lesion. I actually want to credit the team here that, they were able to get, the management team, they were able to get this PET scan, and then they found that there were other lesions that were perhaps less risky to biopsy. Like a iliac lesion is probably safer to biopsy than that chest wall lesion, just given the other structures that are in the chest that are important, of course. And I would tell the patient, we're setting you up for a biopsy, and then we're going to make sure you have a clinic visit to follow up on these findings and to discuss next steps. And I always like to reiterate to patients that we are in the information gathering stage. So, I understand the anxiety that surrounds this workup, but, try not to worry too much. Once we have a diagnosis, we'll make sure that the right doctors are able to help you come up with a treatment plan and talk to you about the best next steps.
Yeah, thank you so much. Okay, I think I would be sort of curious, and maybe all of us here, how you think about these pathologic findings too. Yeah.
So this patient, in summary at this point, has a biopsy proven ER negative, PR negative, HER2 positive breast cancer recurrence. And this is unfortunately now consistent with the diagnosis of metastatic breast cancer, stage 4 breast cancer, that is HER2 positive. It would be interesting, I know that we didn't have the receptors from the initial DCIS to find out what those receptors were. In a portion of cases, maybe about 20% of cases of DCIS, they are HER2 positive at the get-go. We don't routinely check those, so we may not actually ever have that information, even if we were to get the receptors, because for DCIS, we don't actually treat patients with Herceptin, given that the prognosis is overall very good here. So in terms of the management, I think that this patient now has HER2 positive metastatic breast cancer, bone-only lesions, which of course is a better prognostic marker than having liver metastases or lung metastases, brain metastases, and so forth. So the treatment that has been recommended for this patient in the outpatient setting, which I believe was pertuzumab, trastuzumab, and a taxane, that's what we call the Cleopatra regimen. So this was actually a study that was conducted several years ago that randomized patients who had HER2 positive breast cancer, metastatic or advanced breast cancer, to treatment with pertuzumab, which is a HER2-directed antibody, and trastuzumab, also known as Herceptin, that might be one that you are more familiar with, also a HER2-directed antibody, and a taxane chemotherapy. In that study, they actually looked at docetaxel as the taxane, but in clinical practice, often many of us will trade that out for weekly paclitaxel because it's a little bit has less side effects and for patients. But they compared this, the pertuzumab, trastuzumab, and taxane, what we call the THP regimen, to the current standard of care at the time, which was trastuzumab and a taxane alone. And what the authors were able to demonstrate was that the THP regimen actually resulted in a significant improvement in median overall survival at 56.5 months compared to 49 months with just the trastuzumab and taxane. And in addition, the median progression-free survival, that's the amount of time that the cancer stays quiet and the patient stays alive on that current therapy, was increased by 6 months with the addition of pertuzumab to trastuzumab. So that has been our first line therapy for many years now. So the THP regimen, very appropriate. Now, to be fair, that may actually be challenged in the near future by a new drug called trastuzumab deruxtecan that has been approved in the second line setting for HER2 positive advanced breast cancer, but eventually that might actually get moved up to the first line setting based on some ongoing trials and some very promising response rates. But for right now, the current standard of care would be THP. And I think you also mentioned that the patient is getting zoledronic acid, Zometa, which is very standard. Typically in a patient with bone metastases, we would start Zometa and continue that every 3 months, at least for the first year. That not only treats the bone metastases, but also strengthens the bones to prevent fractures, because if you have a bone metastasis, unfortunately that area may be more prone to fractures. And the only other thing I would just add is going back to what I was mentioning with the Cleopatra regimen. I wouldn't, harp on the overall survival outcomes too much, because the landscape of the field has changed tremendously since that study was published, I think back in 2015. So the actual overall survival, which is looking at, from the time that the patient was started on cancer-directed therapy to death, unfortunately, from cancer, is probably longer now if you were to repeat this study, just given that we have more effective treatments in the second and third line setting. And, I think for the residents who are joining us, typically for the management of metastatic breast cancer, this is unfortunately an incurable disease. It is a life-endangering disease. Eventually, a patient will die from breast cancer. That being said, our therapies have improved quite a bit, especially for, in HER2 positive disease. We have a number of new antibody drug conjugates that are being explored. And as I mentioned before, trastuzumab deruxtecan is one that has actually been approved in the second line setting. So typically for a patient with advanced and metastatic breast cancer, this is a chronic disease, and they start on a treatment. They're on treatment A for X number of months. And with time, when things progress, then they switch to treatment B, and you continue like that until there is, unfortunately, unacceptable toxicity, or running out of options, or the patient, on goals of care discussions, you decide mutually that the patient wants to focus more on quality of life and so forth. And the last teaching point that I'll add, this is actually hot off the press at our big breast cancer conference in December, the San Antonio Breast Cancer Meeting. There was a study called the Patina study that looked at adding palbociclib, which is a CDK4/6 inhibitor, with the anti-HER2 targeted therapies, trastuzumab and pertuzumab, versus the anti-HER2 therapies and endocrine therapy alone. So both arms got endocrine therapy after induction therapy with trastuzumab and pertuzumab. So basically, like after these patients with hormone receptor positive, HER2 positive breast cancer had started with THP, eventually after that induction cycle, about like 6 to 8 cycles, they were having a nice response. Then they switched them to endocrine therapy with the 2 antibodies, dropped the chemo, and then in one arm added a CDK4/6 inhibitor, and then the other arm continued with without the CDK4/6 inhibitor. And they showed that this approach of adding the CDK4/6 inhibitor actually improved progression-free survival. Unfortunately, this patient would not be a candidate for that, because I think we said that this was estrogen negative and progesterone receptor negative, so she's not a candidate for that. But that is something that you would think about if the tumor had tested positive for those receptors.
She actually is ER positive, so this.
Oh, is it ER positive? Okay, sorry. The notable lab finding section says ER negative. So okay, so that would be an option for her then. After having initial treatment with the THP regimen for 68 cycles, we'd re-image her, and if she's having a nice response, you could drop the chemotherapy, and then I would probably add palbociclib, which is a CDK4/6 inhibitor, with trastuzumab and pertuzumab, and then endocrine therapy like an aromatase inhibitor in that setting.
Wow, this is certainly a lot of new things and learning for me. A lot of nuances to the treatment. I think I'm definitely gonna rewatch this session a couple of times. Andy, would you like to give us just a little bit more information about the course of the patient, how they're doing, and yeah.
Absolutely. I was curious to look into that myself yesterday. The patient has been started on this therapy, as I mentioned, and they seem to be tolerating it well. They're actually coming up for their first restaging scan just shortly. So we don't have any information to say exactly how they're responding to treatment, but I can at least say, fortunately, they seem to be tolerating treatment reasonably well.
Thank you so much, Andy. This was really a fantastic case, and I think a lot to reflect on, right? So, Dr. Vidula, what we usually do at the end of these sessions is ask our discussants to highlight like 2 or 3 points that they want everybody to take away from the session in terms of learning from the case and from the patient.
So the first teaching point that I would suggest here is that in a patient who has had a history of a prior malignancy, malignancy should be on the differential for, you know, future symptoms, especially if they're unremitting and continuing for many, many months. So I think that this case was very appropriately managed in terms of thinking about breast cancer being a recurrence. So that is something that I think in terms of thinking about your differentials, you definitely need to think about cancer recurrence highly for patients who are presenting with unusual symptoms after an initial diagnosis. The second teaching point that I would make is that I think it's really important in terms of managing and diagnosing a malignancy to make sure that you're staging the cancer appropriately, and that's where the scans come into play. And then also obtaining a biopsy of a metastatic lesion for receptor confirmation, for confirmation of the diagnosis, and to have tissue available for next generation sequencing in the future, and also clinical trials. And then lastly, you know, even though breast cancer is one, you know, is all falls on the, it's actually an umbrella term, you know, it's a series of diseases, and the way we manage breast cancer differs significantly depending on the type of breast cancer it is. And that's why it's really important to categorize the subtype of breast cancer and think about targeted therapies appropriately.
Yeah, I'm so happy that the patient got to have you as their expert and guiding them through this this disease. Andy, is there anything you would like to add?
Yeah, I think that just to emphasize that this is an atypical presentation, that when you have a patient this far out, it often does fall down in the differential, but to at least have it in the back of your mind and think about the presentation over time, the fact that these symptoms were worsening over 9 months, when you actually start to think about some of those features, malignancy, even if it was a new primary, becomes higher on the differential. So just a good case to remind us to always be thinking about that.
All right. Yeah, thank you both so much for being here today. It was an absolute pleasure to have you, and I hope it's just the first of many times. I hope you have a great rest of your day, all of you, and see you very soon.
Thank you
Thank
for
you all
having
for putting this
us.
together.
Bye.